Hello dear student, this is Dr. Sahar from DentaBest, your best online mentor for the preparation of INBD, ADAT and AFK exam. Today I have taken a topic of pediatrics, that is restorative dentistry in the primary teeth. In this video we are going to discuss first of all the anatomical difference between the primary and the permanent teeth, then how the cavity design principle is different in primary molars as compared to permanents, plus what are the important restorative materials that we are using for filling the primary tooth. Let us start with the discussion here. First of all, we should know what is the basis of pediatric dentistry. As in, all the primary teeth have to fall off. Then why we need to do the pediatric dentistry here? The reason is the primary teeth are the best space maintainers we have for the permanent tooth. So they are going to maintain, preserve the arch space until it's the right time for the permanents to come. Now, what are the general consideration for restoration procedure in children? Of course, so first of all, you have to see in the X-ray what is the developmental status of the dentition, the stage of the root development, then caries experience of the patient, oral hygiene, patient cooperation level, that's very important. Now let us see and try to understand what's the differences in the tooth morphology. If you compare the primary teeth with the permanent teeth, you can say primary teeth, they are short and fat, means they are wider mesiodistally and shorter in their height incisor-cervically or occlusio-cervically. Thus, we will see that the cervical constrictions, they are very prominent in the primary teeth. If you look at the pulp horns, they are high pulp horns, and that's the reason pulp exposures are very common in the primary teeth. They have thinner enamel, however, the enamel looks more opaque because it is more mineralized than the permanent teeth. That's why they're also called as the milk tooth. It is important for us to have a positive attitude of the dental team at every appointment. Four-handed dentistry, that means you and your assistant together are working it out, and using euphemism. So euphemism is an important term. Euphemism is when you are using the terms in the wording which is easily understood by the child. For example, you are using rubber dam. For rubber dam, you're using an umbrella so that your tooth doesn't get wet. For local anesthesia injection, you are using the term like sleepy tooth bubble. Let us make your tooth sleep with this bubble. If we talk about the amalgam, our preparation cannot be as conservative as we have for composite because amalgam is mechanically bonding to the tooth structure. So for amalgam, you need a very proper form of preparation like a box shape, cavity, buccal and lingual wall converging, because amalgam is bonding to the tooth structure only mechanically. So we need to follow some rules when we are doing the amalgam preparation. Amalgam, simple, quick, cheap, technique insensitive. That's the reason amalgam is still being used in the pediatric dentistry offices, because in children isolation is a big problem and amalgam is not affected much by the moisture. But yes, disadvantage of amalgam always remain is not being adhesive. It requires mechanical retention, and the main concern we have with amalgam is the mercury, the vapors and the health hazards which are associated with it. A composite, of course, it has a micromechanical bonding to the tooth structure. It is aesthetic, tooth colored, but technique sensitive. Moisture control has to be very good, then only you can place the composite. Rubber dam is always required. And of course, as compared to amalgam, it is going to be more expensive. Now, GICs, they are also chemically bonding to the tooth structure, tooth colored, aesthetic. And one very important property of GIC is that it has a fluoride releasing effect. So that also give an anti-cheirogynic property to the GIC. Although GIC is susceptible to erosion and wear, brittle, and does not have as good strength as you can see with the amalgam and composite. Now RMGIs are improved versions. They have good strength. At the same time, they are adhesive, they are aesthetic. But the problem is they have significant wear with time, and they also cause water absorption. You have high viscosity glass ionomers too, which have the fluoride releasing property, and they have high compressive strength. That's a very good property along with a good wear resistance. So it's getting both the good mechanical as well as aesthetic property. However, the color will not match as good as your composites, compomers and other GIC. That is one disadvantage of high viscosity. Water sorption is there, and for polyocet modified composite resin, they are adhesive, aesthetic, simple to handle, radio opaque, but again, they are going to be more technique sensitive like composite, and as compared to GIC, they have less fluoride release. Then the stainless steel crown, we'll discuss more about them in the next video about the full coverage restorations for the primary teeth. Let us see the morphological considerations of the pediatric operative dentistry. As we know, the primary teeth, definitely they are smaller teeth, so they have a narrower occlusal table. Also, their anatomy is not as defined. They have a shallower anatomy as compared to permanent teeth. The enamel and dentine is of course thinner as compared to the permanent, and that's the reason they have higher chance of caries. Contact areas, you can see they have between two permanent teeth, you can see the contact, and between the primary and permanent teeth, you can see there is more broader area of the contact. Now, when we talk about inclination of enamel rod, now this is a very important topic. So if you see in the permanents, the enamel rod are inclined gingivally, but as compared to in the primary teeth, the enamel rod will be inclined occlusally. This is the reason why bevel that you give in the class 2 preparation at the gingival seat will not be required for the primary molars because of the direction of enamel rods. Now the pulp horns, as I already explained it to you, that pulp horns are going to be higher in the primary as compared to permanent. So they're very close to the surface. That's the reason the chance of pulp exposures are higher here. Now when we talk about the class 1 restorations, we know already, as I told you, they are pit and fissure or occlusal surface of premolar molar, or on the occlusal 2/3 of the facial and lingual of the molars on the lingual surface of the maxillary incisor. So we know dental amalgam. We can see the recommendations for dental amalgam. Dental amalgam, of course, as I told you, they are still being used in pediatrics for your class 1 restorations, for class 2 restorations, which are usually the compound preparation or simple preparation, like simple including the one surface or compound including the two surfaces. But when you have the complex preparations, like which is including more than 2 surfaces, like 3 surfaces, MOD, right? So it's better you go for the full coverage or stainless steel crown there. While glass ionomer, we know, is recommended as the luting cements, cavity bases and liners. In primary, you can use GIC, the modified versions of them, for class 1, 2, 3 and the 5 restorations, or even class 3, class 4 in the permanent teeth in the higher risk patients, but which cannot be isolated. So composite cannot be used, then you are going for improved versions of GIC. Or caries control preparations or restoration with high risk caries patients. Now the resin based composites are indicated for class 1 pit and fissure caries, where the isolation is possible, but the preparations are very conservative. They are class 1 which are extending into the dentine, or class 2 in the primary teeth but do not extending beyond the proximal line angle. Like for the multi-surface, composite is not a good choice because composite don't have that good compressive strength. For class 2 restoration permanent, that extend approximately 1/3 to 1/2 of the buccolingual intercuspal width of the tooth, no wider than that. Or class 3, 4 and 5 restorations in the primary and permanent teeth. We also have the cellulose strip crowns in primary and the permanent dentitions. However, resin-based composite, as I told you, if isolation or moisture control is not possible, you can definitely not use them. Or if they are large multi-surface restoration in the posterior, composite is not a good choice. Now, when we talk about the pit and fissure sealants and the PRR, this is going to be my next video. We are going to